All right, LLSA 2021 for emergency medicine. This article, Tracheostomy Emergencies by Bontempo et al. Matt, this is a topic that doesn't bring joy to my heart. It freaks me out, to be honest with you. So walk me through how I can smoothly navigate what truly is an emergency.
Yeah, there are few things more terrifying than a trach emergency. Part of the problem is there are a lot of trachs being placed. There are more than 110,000 trachs placed in the U.S. per year. We're putting them in for a lot of different indications. It could be upper airway obstruction. It could be excessive snoring, which seems really aggressive. And just a long list of potential patients who are getting trachs. The complication rate is really staggering. So the incidence of complications is 40 to 50%. 1 out of 4 patients who gets a trach place is going to be hospitalized within 30 days, which is just mind-boggling. And 1 out of 100 patients is going to have what they describe as a catastrophic complication. Now, when we look at these catastrophes, 90% of them are going to happen within the first week after the trach is placed. But if you're in that 1% and you have a catastrophe, 50% chance that you die. So trachs are all over the place, and they are obviously no joke when they get off track. And unfortunately, they do get off track fairly frequently. The potential complications, they delineate them between the early post-op changes and late post-op complications. Now, there's a lot of overlap. So hemorrhage you see in both cases. Decannulation is a big one. In the early course, you worry about free air and infection. And in the later courses, you worry about things like tracheal stenosis or fistula, so kind of anatomical changes over time. Decannulation is the one that should really keep us up at night. The incidence of decannulation, this is basically you lose the trach. It's not getting air to where it's supposed to go. The incidence ranges from 0.35% to 15%. The decannulations account for about 50% of airway deaths in an ICU setting. Now, if we see a patient, they have a trach decannulation, there are really 2 questions we need to ask. Now, obviously the patient probably isn't going to tell us, but first, when was the trach placed? And second, how long has this trach been out?
Now, what's the importance of that first question, when the tracheostomy was placed?
Yeah, that's a really good point. So the authors of this paper break down old versus new trachs, and the line in the sand they draw is about 7 days. And so they give us a couple different algorithms that we'll walk through that are likely to pop up on the LLSA test and also could help us in clinical practice. But this is the decannulation kind of algorithm. So if you look, a trach less than or equal to 7 days is a fresh trach, and over 7 days is an old trach. So the first step is going to be give the patient oxygen via their face mask. Now, if you're under 7 days, you're supposed to try to recannulate under direct fiber optic visualization. And the goal here is to make sure that you don't put it in a false passage, or make sure you're getting it back in the right spot. Now, if you're unable to do that, or you think you get in a false passage, so that's I don't have the fiber optic scope, or I can't get it through, then in those fresh trachs, you're going to go to oral intubation.
Matt, before you jump onto the tracheostomies that are older than 7 days old, we're only oral intubating when they're an extremis, right? I'm not just going to be intubating them because their trach fall out. This is really a trach that fell out and is no longer working to get air to that patient.
Right. I mean, ideally, we go down the steps that they lay out here and troubleshoot short of orally intubating them. But yeah, if they're an extremis, we need to go to oral intubation.
Okay.
So that's the breakdown is fresh trachs only recannulate if we have direct fiber optic visualization available. Now, in an older trach, if it's been there for more than 7 days, the guidelines would say we can recannulate the trach just blindly. We've got a good track, we can put it through, but then we need to confirm it with direct visualization. And then if we look and we can't confirm it, or we're in a false passage, we're back to this oral intubation. So when you're looking at a trach decannulation, think, is it older than 7 days, or is it equal to or less than 7 days? Because that's going to guide, do we have to use fiber optic visualization when we try to put it back in the first time?
Versus just direct visualization, you mean looking at it with my eyeball, yeah, okay, it's in, and you're breathing through it, it's working.
So that's a good question. So the pearl is, if the tracheostomy is displaced within the first 7 days, recannulation should be attempted under direct fiber optic visualization. Now, if it's over 7 days, you don't have to use the fiber optic visualization to recannulate it, but they do say to confirm it with that, which for me is a step that I haven't always taken. The second pearl here is, if you're unable to assess fiber optic direct visualization, we should secure the airway via oral intubation. That's what we talked about. This is ideally in a patient in extremis, but ultimately, if we can't make sure it's going in the right place, we need to do something that we're sure of, which would be oral intubation. Next complications they go through are tracheostomy obstructions. So the body doesn't like artificial things in it. Things like trachs love to get clogged up. So it's secretions, it's mucus plugs, it's clotted blood. The tube itself can get displaced. You can get granulation tissue, or the tube could be in a false lumen if somebody tries to recannulate it. So this is basically the trach. It looks like it's in the neck, but it seems obstructed. And they give us an algorithm here. So the first step is always going to be to oxygenate the oropharynx and the tracheostomy. So put oxygen on the patient. Remove external devices. So if there's a trach collar, if there's straps, basically just get at the trach site at the patient's neck with everything else gone. The big key step here is take out the inner cannula if it's present. So a lot of these trachs that we see are double lumen. Take out the inner lumen. And then what we want to do is try to suction down the tracheostomy. If that doesn't work, then what we're going to do is we're going to deflate the cuff of the trach. And the goal there is that lets us oxygenate around this obstructed tube. And that lets us buy a little time, hopefully. But if nothing's working, we need to take the trach completely out. And then we bag ventilate the patient and or intubate the patient as necessary. So start with oxygen, take out the inner cannula, try to suction, but then work your way down to you may have to just actually orally intubate this patient.
Matt, just a quick question on the first step, the oxygen to the oral pharynx and the tracheostomy. Look, I know how to do the oxygen to the oral pharynx. I'm going to be putting them on a mask or maybe nasal cannula. Do you have any tips or tricks for how I would do that on the tracheostomy?
Yeah, so the article kind of goes into some detail here about how do we oxygenate and ventilate patients with a trach, because in a lot of situations, if we put the bag valve mask over their mouth and bag them, air is just going to come out the trach site if the trach is out. So they talk about if you're going to bag them and the trach has been dislodged, we want to cover up the side of the trach when we bag them via the bag valve mask through their mouth. And the counter to that is that if we're going to bag them through the trach site, we want to try to close their mouth, because basically, again, we want the oxygen to go down into the lung rather than just kind of coming out either the mouth or the trach. So second pearl here, for tracheostomy obstructions with double cannulas, which is what most of the trachs that patients are going to have, remove the inner cannula before suctioning. Tracheostomy hemorrhage. Again, this is often an early complication, and about 5% of cases have some degree of bleeding. The thing that we would worry the most about, this is the atomic bomb of potential trach complications, is the tracheoinnominate artery fistula. The authors come out and say this is the deadliest potential complication. It happens in 0.7% of cases, so it's not super rare. It's got a 90% mortality. And when we're looking about who would have this complication, it's an early complication typically. So 75% of the tracheoinnominate artery fistula bleeds will happen within the first 3 weeks of trach placement. They talk about beware the sentinel bleed. And so that's going to typically look like a patient who's has a fairly fresh trach, so first 3 weeks, and says, I had some bright red blood, kind of pulsatile bleeding, brisk bleeding that started at home and typically has stopped, just like we think about sentinel bleeding with other events. If a patient has that story, we have to really pause and say, I know you're not bleeding here. Could this have been the sentinel bleed before your fistula really burst loose?
And clinically, that's a really important point, Matt, because I'm thinking about this in my fresh trach patients, the one that you talked about, less than 7 days or really less than 3 weeks. And oftentimes this is a fresh wound. So you will occasionally get just some bleeding from the wound that the patient will come in. And so I err on the side of caution. And if it's that fresh and that new, I'm touching bases in general with my ENT just to run the case by them and make sure that we're not missing, like you said, that sentinel bleed, having them come to evaluate them because they just did the surgery to really make sure we're not missing this deadly complication.
Yeah, I agree. ENT is not very cavalier with these. So if you call them and say, I think I had a sentinel bleed that may be heralding a tracheoinnominate fistula, I found they're pretty responsive. And that even shows up in this algorithm. So this is the algorithm from the paper about management of tracheostomy hemorrhage. I love the first step: mobilize vascular surgery, IR, and ENT. So recognize you have a potential catastrophe, call your friends. And when you look at this algorithm, it's a little bit tricky at first, but really every step is going towards two things. It is, how can we put pressure on the potential bleed while expediting the patient's kind of path to the operating room? So the first step is to apply pressure to the sternal notch, just kind of external pressure. The thought being that this is a way to put pressure on the tracheoinnominate fistula. So we're really just directly stopping the bleeding as best we can. And then it branches into, what do you do if you have a cuffed trach versus an uncuffed trach? Because that cuff is going to be something that could help us. So if you have a cuffed trach, the next step after you put the pressure on the sternal notch, if they're still bleeding, is going to be to inflate the cuff to maximum volume. And that's 50 cc's in some of these. So you just get that balloon as full as you can to try to put pressure on the trach. And then you want them to go to the operating room so someone can definitively fix this. It's a little more complicated if they have an uncuffed trach, and specifically if it's greater than 7 days old. So what these guidelines would say is, if you're looking at this and it's an uncuffed trach, you want to take the uncuffed trach out. Then you want to intubate the stoma. And again, over 7 days, you should have enough of a stoma to get a tube through, but you want to put an endotracheal tube into the stoma, pump that balloon up in the endotracheal tube, overinflate the cuff. Again, trying to put direct pressure on the source of the bleeding. If we put that endotracheal tube in the stoma, blow up the balloon, and it stops the bleeding, then we're off to the operating room for the repair. We've temporized things. The problem is, if that doesn't work, then we have to take some other steps. So the guidelines here say, first you want to orally intubate the patient. So you've tried the tube in the stoma, didn't work. And then what you're going to do once you get them orally intubated, now you're managing their airway, you're oxygenating them, is you're going to take out the tube that you had placed in the stoma. So basically take out that trach that you replaced with the endotracheal tube. And then you're going to put your finger into the stoma and try to manually compress. So this is the internal version of what you did up at the top with applying pressure to the sternal notch. Hopefully that stops things, because there's no further step they give us. We stop the bleeding there, we go to the operating room for repair. So every step we take is moving towards the operating room and trying to put some type of pressure, whether it's external, whether it's through a tube, or whether it's our finger in the stoma, to try to get that bleeding to stop.
Yeah, so just to clarify, right, Matt, to make sure I'm on the right page here, the oral intubation, that's when I'm no longer using the tracheostomy, the stoma, to ventilate. I'm going to be ventilating them through the ET tube going in their mouth, past the vocal cords, and now I have that open stoma that I can put my finger in and put anterior manual compression on that bleeding site.
You got it. So the pearl here for tracheostomy bleeding: apply sternal notch compression, and if necessary, maximally inflate the tracheostomy balloon to try to temporize that bleeding. Tracheoesophageal fistula, the clinical presentation is variable. So they may have a persistent air leak, they could cough, they could aspirate, they could have abdominal distensions. Occasionally they'll have respiratory distress. From an ED standpoint, the goal is really to stop airway contamination. So we want to elevate the head of the bed, make them NPO, suction the trach. This is not a typical kind of 5-alarm fire like some of these other complications. Other things that can happen to get off track with trachs: infection is actually fairly rare. It should be pretty obvious if there's pus pouring out of it, and maybe that's infected. Tracheal stenosis is common. Remember from the beginning, that's a late complication. It almost never needs an intervention, and it's almost certainly not going to be the cause of an emergency complication. Cutaneous fistula is going to be a kind of persistent track in the skin following decannulation. So again, the patient may complain about this, you may pick this up, but this is not going to typically be an emergency.
All right, Matt. So my take-home points is, look, these have a lot of complications, and some of those complications can be really deadly. So these aren't patients that I'm letting hang out in the waiting room. I'm going to see them immediately. I'm going to think about, look, did I lose my trach and my stoma because it either fell out or it's obstructed? So taking out that inner cannula and all the outside stuff to make sure that can open up is going to be important. And then really the other one is the bleeding, which is the other dreaded complication. That's no good, and I get scared of it because there's that artery that's there. I like the sternal notch compression. I like the overinflating the balloon. I like that I have the option to, look, just go old school, go ET tube in the oral pharynx and get your finger in there and compress from the inside. While you've given me some great algorithms, I'm still worried about this diagnosis. I do feel some comfort that I have some steps to follow and get my ENT on board early to go to the OR.
This is Hippo Education.